So let's start with the first module in general surgery. Now, general surgery is a very important topic for your exam, and this is something which is not routinely discussed in your colleges and in government institutions. But this is assuming a lot of importance in today's era of litigations and cases on doctors. So I'll be talking about these very important topics, and lots of MCQs have been asked from this. From this module, very few questions come in your college exams, but I would still recommend that you listen through this module because it's very interesting, and when you start practicing, this would become very relevant for you as well. So patient safety, like I told you, has assumed maximum importance, and there are lots of incidents which have occurred which have resulted in cases against doctors. So what are these kinds of incidents which can take place in the hospitals? You should know their definitions and you should know examples as well. The first one is an adverse event. An adverse event is an incident which results in unwanted harm to the patient, right? So this results in harm to the patient. And the classical example which I can never forget is when I was doing a fellowship in America, there was a patient who was sensitive to clindamycin. And this lady was about to undergo bilateral breast reconstruction. And there you have nurse practitioners who can give anesthesia as well. Now, by mistake, the nurse practitioner did not see the papers properly, and she just gave a test dose of clindamycin. And just with that test dose, the patient went into anaphylaxis. And I can never forget that sight, that the abdominal flaps were dissected. The plastic surgeons were holding them in their hand, and the patient arrested, and there was CPR going on. Fortunately, they were able to revive the patient. After 6 days in the ICU, the patient again underwent surgery and the flap was done. But that was an adverse event, right? A near miss event is that an event which could have resulted in harm to the patient, but because of timely intervention, that harm has been prevented, right? Because of timely intervention, that event has been prevented. And the example for this was a patient of ours where the surgery had been done, and again the patient had had a reconstruction, the latissimus dorsi flap, and the anesthetist had put in an epidural catheter, right? And epidural catheters have to be topped up so that the patient can get pain relief. And we were just about to enter the room for our rounds, and we saw that the nurse, instead of giving the anesthetic top up in the epidural, was giving it in the IV line. And that could have been catastrophic because you know that bupivacaine has cardiotoxicity, right? And we just stopped that nurse. So that will be counted as a near miss event. And whenever you have such near miss events, we always document it. There is a form which is raised, and there is an incident form which we fill out, and there is an incident meeting which takes place to understand that why did that thing happen or was about to happen, and how can we prevent it in future. A no harm event is that a problem happens but it does not result in harm to the patient, right? So incident that occurs and reaches the patient but results in no injury to the patient, that is a no harm event. So an example for this was that a patient, when I was in Safdarjung, we had written that patient on bed number 12 requires an enema, and we told the intern that you have to give the enema to bed number 12. Instead of bed number 12, the intern and the nurse gave the enema to bed number 13. Okay. Now, the enema was given. There was no harm caused. The patient just passed stools. So there was no harm caused, and only when we inquired whether the bed number 12 patient got the enema or not, then only we got to know that he did not get it, but the other one got it. So that was a no harm event. Now, these three events tell us about how robust the patient safety systems are there in the hospital. But the most important data regarding patient safety in a hospital, the most important data regarding patient safety in a hospital is the near miss data. Right? So near miss data is the one which is the most important data, which tells us how robust the patient safety norms in the hospital are. So this is the first thing. You should know the examples of these three types of adverse events. This I've already told you. Now, once the patient gets admitted in the hospital, as an intern or as a member of the surgical team, you have to take the consent, right? That's the first thing which you do when the patient gets admitted. Now, consent is always a written consent, right? consent is always a written consent which we are going to take. And what all does the consent include? That is very important. So the consent will include the identification details of the patient, the name, the age, the sex. So identification details, the registration number which has been allotted to the patient, the diagnosis which the patient has, the procedure which is going to be performed on the patient, the name of the surgeon, the description of the procedure, right? So if I'm going to do a modified radical mastectomy, I have to write it in simple terms. I have to write that I'm going to remove the breast and I'm also going to remove the lymph nodes. Then you also have to include the patient-specific complications, right? So patient-specific complications, the patient might be a case of COPD, right? Or the patient might be diabetic. So COPD patient might have more respiratory problems in the postoperative period, whereas a diabetic patient might have more wound-related complications. So that you have to document. Then procedure-specific complications, right? So supposing I'm doing a mastectomy, seroma, that is accumulation of fluid, is the most common complication. Lymphedema can occur. Flap necrosis can occur. Recurrence can occur. So all these things we need to document in the procedure-specific complications. Now, there can be many procedure-specific complications. We don't include all of them. We only include those which have an incidence of more than 1%. Only those complications which have an incidence of more than 1% are to be included in the consent. The next thing which you need to mention are the benefits which the patient is going to get from the procedure. So if I'm doing a mastectomy, we are treating the patient of a cancer. Very important, alternate procedures which are going to be performed, right, or have been offered to the patient. So whenever we fill in a consent, if the patient has opted for mastectomy, we will always write in the alternate procedures breast conservation surgery. Or if the patient has opted for breast conservation surgery, we will always also write mastectomy as an alternative procedure explained. Right? So alternate procedures also we need to write. And the patient needs to sign this, the surgeon needs to sign the consent, and a witness needs to sign the consent. Now we also sometimes get foreign patients, like I get patients from Iraq, Ukraine. So there the foreign interpreter, the person who understands their language, also has to sign the consent. And in the case of a minor patient, right, the guardian has to sign. The guardian has to sign the consent as well. So let me just show you how our consent form looks in the hospital. So this is the consent form. You can see age, gender, registration number, interpreter service if it's a foreign patient, the name of the consultant, the diagnosis, the medical condition which the patient has, the procedure which the patient is going to undergo. Then the risks of the procedure are explained to the patient. The risks are explained. Patient-specific risks are explained. And benefits which the patient is going to get from the procedure. Okay. We also then explain alternatives explained to the patient, right? So what are the alternative procedures which have been explained? And finally, the patient has to sign this consent. So you can see here that the patient has to sign, the witness has to sign, and if an interpreter is being used, the interpreter also has to sign the consent. So once the patient has signed the consent, then the patient can be shifted to the theater. But before we shift the patient to the theater, we always need to put in an IV line, right? IV cannulas, IV access needs to be achieved. And there is a color coding of IV lines which you should know about. And this color coding of IV lines is asked in almost every exam. So IV lines, questions from IV lines are definitely asked. So IV lines or IV cannulae. 14 gauge is orange in color. 14 is orange. Gray is 16. Gray is 16. Green is 18. Pink is 20. Blue is 22. And violet is 26. So that is the color coding which you need to remember. This color coding has been asked multiple times in the exam. Now you should also know that an orange cannula is the thickest cannula, right? Is the thickest or has the widest bore. And if it has the widest bore, what is the significance? There will be fastest flow rate available as well. there'll be fastest flow rate, because if the cannula is thick or wide, fluid will flow quickly through it. So if you have to give fluid quickly, you will put in a wide or a thick cannula so that fluid can flow quickly through it. As the number increases, the cannula becomes narrow, right? Cannulae become narrow. So this is narrowest. In fact, 26, which is violet, is the narrowest, and that will have the least flow rate. That is going to have the least flow rate. And as interns, one thing which you will master in 1 year of your internship is cannula insertion, right? So all of you become experts in cannula insertion. In fact, we often used to say that an intern is the best person who can put in a cannula if nobody else can get it. And a consultant is the worst person, because the consultant is not used to putting cannulas only in government hospitals, right? So interns are the best trained in putting cannulas after, of course, 7-8 months of their internship. So this is the color coding, and last year in the exam, they also asked the flow rates, right? Flow rates were asked in the exam. So you should remember that orange, which is 14 gauge, is 270 milliliters per minute. Gray is 230 milliliters per minute. This you can remember as 240, which will be easier to remember. 270, 240. Green is 103. This is what was asked. Green was asked in the exam. Pink is 67. Blue is 31. And yellow is 13. So pink you can remember as 60 and blue you can remember as 30. So they're just multiples of 30 which you can remember, right? And that ways it becomes easier for you to remember. You need to remember the flow rates because this is extremely important for the exam. Now, everyone is very happy when you see wide veins. You know that you can put in a cannula easily. And whenever you see such veins in a patient, both the interns and the nurses are super happy. Now, cannulas are not without complications. There can be superficial thrombophlebitis. Now, superficial thrombophlebitis is the most common complication of IV line insertion. And lots of questions have been asked regarding that as well. This is actually my hand, and this was when I got admitted for COVID in the hospital. I also developed superficial thrombophlebitis, and you can see a reddish cord here, right? You can see this vein was all inflamed, and you can feel a cord-like structure, right? You can feel a cord-like structure, and it takes at least a couple of months for this cord-like structure to go away. So that is superficial thrombophlebitis, which is the most common complication of IV lines. Now, like I told you, that if you get a question in the exam where you get a trauma patient, supposing you get a trauma patient or you get a patient after diarrhea who is hypotensive, right? This patient is hypotensive. Now, if the patient is hypotensive, do you have to give fluids quickly or will you give them slowly? Of course, you'll give them quickly, right? Patient is hypotensive, he's dehydrated, needs fluids. So in these patients, we will use the widest possible cannula. We will use the widest possible IV line so that we get the fastest flow rate. Please remember this. So supposing the options were gray, green, pink and blue, you will put in a gray cannula because that will have the fastest flow rate amongst those four. So such questions, such practical questions have also been asked multiple times in the exam. You should also know that in burns patients, if you have to put in an IV line, we use a wide bore cannula because we have to give fluids quickly. Burns patients are dehydrated, and we have to use a long IV line. Why a long IV line? Because in burns, there is edema. And if you use a short cannula, in burns patients, there is edema, and if you use a short cannula, it will come out of the vein. That is why we use a long length cannula in burns patients. So these were some points regarding IV lines which I wanted you to know. Other IV access in the form of central line or PICC line, these I've covered in the nutrition module. So you should go through the nutrition module as well. I've covered about PICC lines and central lines in detail there. So once we've put in an IV line, now our patient who was admitted for surgery is ready to be shifted to the OT. But when you go to meet the patient is really scared. The patient says, I don't want to go, I'm very scared because I heard a case which happened in Delhi 3 years back where the patient was supposed to undergo a left knee replacement, but the orthopedic surgeon operated on the right knee. And this case actually happened, right? So when you meet such a patient, you have to tell the patient, well, that was a one-off case, but there are a lot of safety checks in place which prevent that from happening. Okay. So the patient asks you, what are those safety checks? So one of those safety checks is the surgical safety checklist. And this surgical safety checklist has led to a dramatic reduction in mortality in hospitalized patients. And the mortality has gone down. So mortality has gone down from 1.9% to 0.2% since the use of these surgical safety checklists. Okay, since the use of these surgical safety checklists, they've gone down from 1.9 to 0.2%. And that is the beauty of these checklists. In fact, I feel all doctors should read this book from a surgeon called Atul Gawande. He's a professor in Harvard, and he's written a book called Checklist Manifesto, where he has discussed how the application of checklists in various professions has led to an improvement in the productivity and reduction in the complications, right? So this surgical safety checklist is used routinely in our corporate hospitals whenever we are about to operate a patient. So what all this does this surgical safety checklist entail? The surgical safety checklist has three major components, right? The three major components are the sign-in phase, the time-out phase, and the sign-out phase. These are the three major components of the surgical safety checklist which are there. One of the questions which was asked in the PGI exam a few years back, which is not a component, so there is no time in. There is no time in. This question has also been asked. So the sign-in phase is when the patient is shifted from the ward to the OT complex, and that is when sign-in happens, right? So the OT receiving nurse, the staff who receives the patient from the ward will do the sign-in. And in the sign-in, what all is confirmed? The identity of the patient is confirmed, right? We make sure that we've got the same patient and not somebody else. So there is a tag which is put in which has the name, which has the registration number. So identity is checked, the registration number is checked. Okay, the diagnosis is checked. The procedure planned is checked. The procedure planned is checked. Then the other things which are checked, very important, which has been asked in the exam, is site marking. Right, so whichever site is to be operated, that needs to be marked with non-erasable ink. What does that mean? Supposing I have to do a left-sided breast surgery, so my team member in the morning is going to put a mark on the left hand with non-erasable ink, right, to signify that the surgery is on the left side. And this we confirm from the patient. We ask the patient to say which side is your surgery planned, which side is the problem. Then we cross-check with the reports and then we put that mark. Now, until and unless this mark is put, the patient cannot be shifted to the OT. Nurse will not allow the patient to be shifted to the OT. So site marking also prevents wrong side surgery. Then we also have to find out if the patient has any allergies. If the patient has any allergies, they are also to be documented in the sign-in phase. Now, after this has your time-out phase. Time-out phase is when the patient is about to be, we are about to start the surgery. So before induction of anesthesia or before incision. So different hospitals have different policies. Some people have before induction, some people have before incision. And there are two nurses in the OT. One is the scrub nurse who washes up with you, and the other one is the circulating nurse who will hand out instruments. So the circulating nurse says time out, and everyone stops when she says time out. Everyone stops, and the first thing which everyone does is everyone introduces themselves to each other. Introduces themselves to each other. Okay. Now, this is very important because this serves as an icebreaker for you to know who your anesthetist is, who the nurse is. In a small hospital, this does not matter. But like when I was in, I'd done a rotation when I was in Harvard, and there were 27 OTs there. Now, with 27 OTs, you can imagine how much staff they will have. Right? So, not everyone knows everyone. So, that is why everyone has to first introduce themselves to each other. And I will show you videos of each of the phases so that you actually know what is done before we are starting a surgery. So, everyone introduces themselves to each other. Then we recheck the identity. We recheck the identity of the patient. Then the surgeon has to say what is the diagnosis, what is the procedure which is planned, and how much time will be taken. Procedure planned and time required to carry out the surgery. Okay. So these are the things which are asked from the surgeon. The anesthetist who's there, the anesthetist will tell us what is the ASA grade of the patient. Dr. Chaitanya must have covered the ASA grading with you in anesthesia. Then the anesthetist also has to say any risks associated with the patient. So is the patient diabetic, hypertensive? Are those risks involved in this patient or not? And the anesthetist also asks a very important thing. When was the prophylactic antibiotic given? Prophylactic antibiotic, what time was it given? So in the subsequent modules, I've told you that the best time to give prophylactic antibiotic is 30 minutes to 1 hour before surgery. So the anesthetist is going to confirm that at what time was the prophylactic antibiotic given. And the nurse who's washed in with us, is going to be asked that has sterility been confirmed? Has sterility been confirmed? And are all equipments in place? All equipments required for this procedure are in place or not. Okay. So these are the questions which are asked in the timeout phase. Now, before I move to the sign out phase, I would want you to see the videos of both sign in and timeout phases.
Sushila Sagarabad and site bilateral breast and consent taken. Surgery site bilateral, so not applicable. Is anesthesia machine and medication check complete? Sir?
Complete.
Okay. Patient have allergic to injection augmentin, difficult airway or aspiration.
No normal routine anesthesia.
Risk of blood loss?
Less than 100 cc.
Okay. Please confirm all the team members by the name and role.
Dr. Rohan, surgeon.
Rakesh Prabhnath, Dr. Abhishek, anesthetist.
Nisha flow nurse.
Rahul, technician.
Okay. So what procedure, site and duration are planned?
Procedure plan is right breast microdocectomy. Procedure is going to take 40 minutes. Blood loss expected is less than 100 cc. There are no critical steps from my side.
Thank you, sir. To the anesthesia team, are there any patient-specific concerns?
No specific consent. ASA grade 1. Antibiotic given at 10:20 a.m.
Okay. What monitoring equipment or other specific level of support are required?
No.
To the nursing team, has the sterility of instruments been confirmed?
Yes.
Are there any equipment issues or concerns?
No.
Okay. Time out done. Thank you.
Thank you. Now, one more thing which is very important, which is asked from the surgeon, is the expected blood loss. Is the expected blood loss. So the surgeon is asked, how much blood loss do you expect in this surgery? And surgeons will always under quantify this, right? If there is going to be 100 cc of blood loss, they'll just say 510 cc. Or if there's going to be 500 cc, they'll just say 100 cc. So surgeons have a tendency, they'll always speak the lower amount. So now once the surgery is done, we move to the sign out phase, right? We move to the sign out phase. So sign out phase is at the time of skin closure. That is when the sign out phase happens. Now in the sign out phase, what is the role of the surgeon? So the surgeon is asked, what is the actual surgery performed? Actual surgery which was performed in the patient. Okay. Any complications which they expect, and any equipment issue which they faced during surgery. So all this is asked from the surgeon. The nurse has a very important role in the sign out phase. The nurse is asked, are all the gauze pieces and equipment counted for? So you know that we use gauze pieces and we use mops during surgery. Those smaller ones are gauze pieces, the bigger white one is the mop. So gauze count and mop count, is it correct? So if they opened up 10 gauze pieces before surgery, have they counted 10 gauze pieces again? Is something being left inside? So all these have to be counted. All needles and all equipment count. Is it correct or not? Now this is very important, and complications can happen anywhere. And again, something which I've seen in a place like Harvard, where I was posted in the bariatric surgery unit. So this patient had to undergo a sleeve gastrectomy, and at the end of the procedure, the nurse was counting the number of needles used, and one needle was short. And then ultimately they had to bring in the C-arm. C-arm is the C-shaped thing where you can do a real-time X-ray. So they got the C-arm, they did that C-arm shot, and they found that the needle was sitting on the spleen, and the surgeon had to retrieve it again. Okay, so this surgical safety checklist helps in preventing problems, and this counting of gauze pieces and mops and needles and equipment is very important so that nothing gets left inside. Another thing is that if a specimen was removed, has the specimen been labeled? So whatever specimen you've removed for pathology, has that been labeled or not? And finally, the anesthetist has to say, what is the actual blood loss? So this is the place where a lot of anesthetists and surgeons get into argument, because as I told you, surgeon will always say, I just caused 100 cc of blood loss. But anesthetist would say, no, you've caused 1 liter of blood loss, right? And that's where the conflict starts. But the final say is always given to the anesthetist, right? The independent view is given to the anesthetist. They tell us how much was the actual blood loss. They also tell us any risks involved with the patient, any risks or complications expected. So these are the 3 phases of the surgical safety checklist, and I've told you the important points which you need to know in each phase, which have been asked as questions. There have been 3 or 4 questions in the last 4 years from surgical safety checklist. Now you should also know that each phase of the checklist is to be signed by the surgeon, the nurse and the anesthetist. Each phase is signed by surgeon, nurse and anesthetist. So this is the surgical safety checklist which we use. I've already told you the important components of each of the phases. So these components you should know for your exam. I've already discussed them with you in great detail. I've told you there are 3 phases. You have the sign in, time out and the sign out phase. Like I told you, the source of conflict, anesthesia says what was the estimated blood loss. Surgeon will call it just 50 cc's, but you will see that the entire suction device is full of blood, all the mops are soaked in blood, and that is where the conflict starts. Okay, so this I told you, the final say is always given to the anesthetist. Now before we move on to the next concept, I want you to watch the video of sign out as well.
Must be confirmed with the team. Has the name of the procedure been recorded?
Yes, procedure done was right microtechectomy and starting skin closure now.
Has it been confirmed that instrument sets and sharps counts are complete?
Yes, counts complete.
Have any specimen been labeled?
Specimen has been removed, it has been labeled, it has to be put in the container.
Have any equipment problems been identified that need to be addressed?
No.
Thank you, sir. Sign out done.
Thank you. Now the next thing is, how do we calculate blood loss in the theatre? So how to calculate blood loss? How to calculate blood loss in the theatre is the question, and there are some practical scenarios also which are asked in the exam pertaining to this. So number 1, you need to remember a soaked mop, a completely soaked mop. That means this big mop which you can see, if it is completely soaked in blood, this is 100 cc of blood. This is 100 cc of blood. The second, we have to look at the amount of blood in the drain, in the suction machine. Amount of blood in the suction minus irrigation fluid used. If you wash the cavity with saline, that much you have to minus. So when you calculate amount of soaked mops and blood in the suction minus the irrigation fluid, plus if you have clots, if there were clots in the abdomen, one fistful of clots will be 500 cc. Like if you've taken a delivery and if you're evacuating the uterus and you get a fistful of clots, that is 500 cc. So once you add these three up, that is when you get the actual blood loss in the theatre. Okay. For example, there were 5 mops which were soaked during surgery. 5 mops soaked during surgery. There was 1200 cc in the suction. There was 1200 cc in the suction, but 1 liter was irrigation. 1 liter was irrigation fluid and no clots. No clots. So it is going to be 5 into 100. So 500 plus 1200 minus 1000. 1 liter was the irrigation fluid. So this is going to be 700 cc of blood loss. So this is how we calculate how much blood loss has happened in the theatre. At some places, they also weigh the mops. So they see how much do the soaked mops weigh and how much do dry mops weigh. And their difference is taken to calculate the amount of blood loss. Now, one more thing which I want you to notice here, which is very important as a safety mechanism. Can you see this bluish line on the mop? This bluish line. You can see this bluish line on the mop here as well. So these, I click pictures after a surgery which I had done. This bluish line, these are radio opaque lines. What is the significance? These are radio opaque lines. And why do you want radio opaque lines on gauze pieces and mops? Because I told you, just in case you forget a mop inside or you forget a gauze piece inside the abdomen, then with these radio opaque lines, you can easily identify them. You can localize where the gauze piece has been left behind or the mop has been left behind. So this is also a safety mechanism which we use during surgery. Now we have all this information. The next thing which we need to talk about are the zones in the theatre. So as an intern, you know, you're called to the OT and you're asked to scrub in, and it's a great feeling, right? Some people do it in second year, third year when their postings start, but majority it happens during internship. And I can never forget that experience because we were the first batch in our college and we were allowed to wash up in cases from second year of our undergraduation. And just stand there also, but that standing there also was a great experience. So you need to know about the zones of the theatre, right? Now, when you enter the theatre complex, first you will go into the protective zone, right? And that is where you're going to change your clothes. So the changing zone will be there. You will change your clothes, you will wear scrubs, right? And scrubs have become so popular after so many of these American soap dramas regarding doctors, Grey's Anatomy, Scrubs, right? So the Good Doctor. So you will wear your scrubs once you go into the changing room. Once you come out of the changing room, you will see the transfer bay where the patients are received and the patients are sent back. The pre and the post-operative rooms and the ICU. All this is present in the protective zone. Okay. And I will show you a video of all these zones as well. I'll take you on a journey through all these zones so that you have a clear concept in your mind and you can retain them easily. The clean zone after that, once you step out of the changing room, so this is me, I've worn my scrubs, come out of the changing room, I come into the clean zone, right? Now this clean zone is the corridor which connects the protective zone to the aseptic zone. Okay, connects the protective to the aseptic. Which is the aseptic zone? The aseptic zone is the actual theatre, is the OT. So this corridor which connects the protective to the aseptic zone is known as the clean zone. And this is where you have your equipment storage room and your maintenance workshop. This has also been asked in the exam. Changing rooms have been asked in the exam. And pre and post-operative rooms have been asked in the exam. Finally, you have the disposal zone where we throw off all the waste. That is the disposal zone. So I just want you to watch a video now and see all these zones which I've described in the video. So we'll go through the various OT zones. I've changed my clothes. I've opened the door and this is the corridor. You can see this is the pre and the post-op room. And then that corridor leads us to the actual theatre, right? So this is the pre and the post-op room which is there. And then this is the corridor and this is the theater door. When I open the theater door, I'm going to enter the aseptic zone. So till now we've discussed about the surgical safety checklist. We've put in IV lines and our patient is now in the theater ready to be operated. Now once anesthesia is given, the surgeon would ask the correct positioning to be done before the surgeon starts the surgery. These OT positions are extremely important for MCQ exams. Invariably, there is one question directly or indirectly related to these OT positions. The first OT position is the most common position, that is the supine position, right? So the patient is lying straight, that is the supine position. And again, I will demonstrate, I will show you a video of all these OT positions so that these concepts are very clear and you can answer all sorts of image-based questions or video-based questions if they are asked in the next exam. So the supine position, the patient is lying straight. This is the most common position which is used, and this is used for abdominal surgeries. It is used for breast surgeries. So abdominal procedures, breast procedures, majority of the procedures are done in the supine position. Now, you must have seen in the theater that if the patient's head end and foot end are at the same level, right? If this head end and the foot end of the patient is at the same level, then we call this the neutral position of the table. We call this the neutral position of the table. So if you see in this image, the patient is in the neutral position. The head end and the foot end are at the same level. But sometimes the head end can be low and the foot end can be raised. So when the head end is low and the foot end is raised, this is known as Trendelenburg procedure or Trendelenburg position, right? This is known as Trendelenburg position. And in the Trendelenburg position, the foot end is raised, the head end is low. This is the foot end, this is the head end. And this is used for pelvic surgeries. This is used for pelvic surgeries. And what is the advantage? Now, if I have to operate in the pelvis and if the patient was neutral or the head end was raised, what is going to happen? All the bowel will fall into the pelvis, right? All the bowel is going to fall into the pelvis. And when bowel falls into the pelvis, it becomes very difficult for us to operate. But if we do foot end up and head end low, then the bowel will move up and we can easily operate. We can easily operate these patients. So this is the Trendelenburg position which is there. Now, if we do opposite of this, that becomes reverse Trendelenburg. In reverse Trendelenburg, head end is raised and foot end is low. Head end is raised and foot end is low. That is reverse Trendelenburg. And where is this used? This is used in positions like lap chole. This is used for laparoscopic cholecystectomy. This is used for lap sleeve gastrectomy, right? So upper abdominal procedures, we will do reverse Trendelenburg. And what is the advantage? The advantage is that when the head end is up and foot end is low, all the bowel will fall down, right? All the bowel is going to go into the pelvis and it will be easier for me to operate in the upper abdomen. Okay? So that is your reverse Trendelenburg position. Now, in the gallbladder module, and the minimally invasive surgery module, I've also told you for lap chole, it is reverse Trendelenburg. It is reverse Trendelenburg with right side up. With right side up so that all the bowel falls on the left side and I can easily dissect the Calitz triangle to dissect the gallbladder. Now the problem here is that when we do this, all the CO2, where is CO2 coming from? CO2 is used during laparoscopy. Okay, refer to the minimally invasive surgery module. There I've told you pneumoperitoneum is created using CO2, carbon dioxide, right? All the CO2 is going to go below the right diaphragm. And when the CO2 goes below the right diaphragm, this can cause referred pain to right shoulder tip. This can cause referred pain to the right shoulder tip, and that is the most common complication following laparoscopic cholecystectomy. And this is because of retained CO2 due to the position of the patient. So you can see how the position is also affecting the complications which a patient is getting after surgery. The next position which we need to know about is the lithotomy position. Now, lithotomy position, I'm sure you must have seen it in gynecological procedures, in hemorrhoids, fissures, piles. So this is used for obstetric It is used for gynecological procedures. It is used for urological procedures. Urological procedures like TURP, transurethral resection of prostate, cystoscopy, transurethral resection of prostate, cystoscopy. It can also be used for hemorrhoids. It can be used for hemorrhoids. It can be used for fissures. It can be used for piles and hemorrhoids, fissures. All these surgeries are done in the lithotomy position. Now you will see in the video as well, in the lithotomy position, the patient, the legs are supported on a stirrups, right? These are stirrups on which the legs are supported and the legs are spread apart as well. So this is the lithotomy position. Now there is adequate padding here, right? We provide adequate padding so that nerve compression does not occur. But if adequate padding is not there, if adequate support is not present, then these patients can land up with common peroneal nerve injury. And this has been asked many times in the exam. They can land up with common peroneal nerve injury. That has been asked. Okay, so you should know about this. Common peroneal nerve injury can be there in these patients. So this is the lithotomy position. This is your lateral or the kidney position, right? The lateral or the kidney position is when the patient is tilted towards one side, right? And you can see that there is a towel roll kept below the legs. There is a towel roll kept below the legs and you have a support to keep them in this place. There is a support to keep them in this place. Now the problem with the lateral or the kidney position is that over abduction of the arm can give rise to brachial plexus injury. This can give rise to brachial plexus injury. Okay, so that is the importance. That has also been asked in the exam. That is the problem with the lateral or the kidney position. Now, as the name suggests, this is used for renal procedures like pylolithotomy, nephrolithotomy, nephrectomies. But it is also used for thoracotomies. If you want to open up the thorax, right? If you want to do a latissimus dorsi flap, right? This latissimus dorsi flap I've covered in the plastic surgery module. It is used for breast reconstruction, right? So latissimus dorsi flap, pylolithotomy, nephrolithotomy, all that is done in the lateral position. Another surgical position is the prone position. Prone position is when the patient is lying upside down. And in the prone position, this is used for spinal surgery. So prone position is used for spinal surgery and this is also used for pilonidal sinuses. Pilonidal sinus I've covered in the rectum and anal canal benign module. Pilonidal sinus is also known as Jeep driver's disease, which is a sinus in the natal cleft. So for these surgeries, the patient is kept upside down in the prone position. So now before I move on to the other positions, I want you to watch this video where I've demonstrated all these surgical positions. So let's talk about the various OT positions. So you can see this is the neutral position of the OT table where the head end and the foot end are at the same level and the patient is lying in the supine position. You can see the controller is there with the technician and he can change the OT position or the table position with this controller. And now you're going to see that we've discussed about the neutral position. Now you will see that in this position, now the head end is going down and the foot end is moving up. Now if the head end moves down and the foot end moves up, we know this is the Trendelenburg position, right? This is the Trendelenburg position, head end down and foot end up. And this is the reverse Trendelenburg position, opposite of that, where the head end is up and the foot end is down. We know reverse Trendelenburg is used for upper abdominal procedures like lap chole, like sleeve gastrectomies. So this is the lithotomy position. This you must have seen that the patient is lying on the back. The legs are spread apart and they're held on stirrups. Now these stirrups which are there are well padded so that there is no injury to the common peroneal nerve. They are well padded stirrups and we don't cause overextension. This is the prone position which I've already told you, which is used for pilonidal sinus surgery and for spinal surgery. So the next position which I want you to know is the Fowler's or the sitting position. Now, this is the sitting or the Fowler's position, and this sitting or Fowler's position is best for CNS surgery. And which CNS area? This is good for posterior fossa because it gives us good exposure. So it is good for posterior fossa. Some people like to use this for breast reconstruction as well, to see how the breasts are looking after reconstruction. So breast reconstruction also, we can do the sitting or the Fowler's position. Now, the advantage of the sitting or the Fowler's position is that there is good exposure. There is good exposure which we get in these patients. And the second advantage is when the patient is head end up and foot end low or is sitting, what is going to happen? That because of gravity, all the blood is going to come down, right? Because of gravity, all the blood is going to come down. So when the blood comes down, we get a relatively bloodless field. We get a relatively bloodless field. So that is the advantage of the sitting or the Fowler's position. But what is the disadvantage? Now the disadvantage is that when the veins have become emptied because of gravity, all the blood has come down. So the veins are empty, right? The veins have negative pressure in them. So if veins are cut, they will suck in air. They can suck in air, and that can give rise to air embolism. Okay, that can give rise to an air embolism, which is a major complication, and the risk of air embolism is increased in the sitting or the Fowler's position. The risk of air embolism is increased in the sitting or the Fowler's position. So you should know about this. This question has been asked multiple times in the exam. Now, to take this discussion further, we are saying that the veins will suck in air. So how can we prevent air embolism? How can we prevent air embolism during this position? So to prevent air embolism, what we need to do is we need to ligate before we cut. Ligate the veins before we cut them. So wherever there is a risk of air embolism, always ligate before you cut. So what does that mean? That means that if this is the blood vessel, I'm going to tie it here, I'm going to tie it here. Tie it on both the sides, and then we cut the blood vessel from the center. First tie and then cut, right? So that air does not get sucked inside. Otherwise, air can get sucked inside and that can give rise to an air embolism. Also, if you visit the neurosurgery OT, you will see that they keep the field covered with saline, right? So they keep on putting saline so that air does not get sucked inside. So we can use saline to coat that field so that air does not get sucked inside. But the best way is to ligate the veins before cutting them. That is the best way to prevent air embolism. Now, air embolism will usually occur if 20 to 50 cc of air is required. Minimum 20 to 50 cc of air is required to cause an air embolism. Okay. And this air can go into the heart. This air can go into the heart and compromise cardiac function. It can compromise cardiac function. So this air can go into the heart and it can compromise cardiac function. And it can also go into the pulmonary circulation. It can also go into the pulmonary circulation and it can affect the pulmonary function also. So if you're suspecting a patient with air embolism, how will the patient present? Supposing the patient is undergoing a thyroid surgery. In thyroid surgery also we have head end up and there is increased risk of air embolism. Right, so during thyroid surgery, the patient can suddenly collapse, right? Or the vitals can become suddenly deranged. The anesthetist would notice that there is tachycardia which is happening, ventilation is becoming a challenge, and the cardiac function, the BP, is suddenly falling. So in those patients, we should suspect an air embolism. And whenever you suspect an air embolism, we always shift the patient to left lateral decubitus and foot end up, right? So left lateral decubitus and foot end up position. This is known as the Durant's position or the recovery position. This is the Durant's or the recovery position in which the patient is shifted. Okay. So durance or recovery position is the patient is shifted in this, and the advantage is that there is right side up and there is foot end up. Okay, right side up and foot end up, and we know gas is going to travel. Gas will travel up, so gas is going to remain. When there is right side up, the gas will remain on the right side of the heart. It will not go towards the left side of the heart, and it will remain on the foot end also. It will remain in the foot end. Okay. So this is the durance or the recovery position, and then we can aspirate air through the central line. We can aspirate air through the central line, or we can aspirate air through the heart using a needle. You can go under guidance and you can directly aspirate air through the heart as well. And that is how we manage a patient with air embolism. Now, one more position which I mentioned for thyroid surgery, and this I've shown in the thyroid surgery module. I have depicted this position when I've shown a video on thyroidectomy. This is known as the rose position. And the rose position is when there is a towel roll which is kept below the shoulder blades. There is a towel roll below shoulder blades. There is a towel roll which is kept below the shoulder blades, and that leads to neck extension. Right? And that gives you more exposure. And there is 30-degree head up. And this 30-degree head up, again, there is less venous congestion. Because of gravity, blood comes down and you get a relatively bloodless field. But the problem is, because there is head end up, there is again increased risk of air embolism. And I've told you how to take care of that as well. So this was the position during thyroid surgery. This is the rose position. Another position which has been asked in the exam is the jackknife position. Now the jackknife position, you can see that the patient is in the knee elbow kind of position, right? You can see how the patient is lying. And this position was earlier used for hemorrhoids, fissures, surgery in the past. But the problem is, you can see in the position that the patient's chest is getting compressed. And when the chest gets compressed, there's not proper ventilation. So why this position is not used now, the reason why this position is not used now is because of positional asphyxia. The chest gets compressed, and that is why we don't use this position. Now this question has been asked in the exam. Another position is the Lloyd-Davies position. Now the Lloyd-Davies position, you can see the combination of the Lloyd-Davies position is a combination of Trendelenburg. That means foot end up and head end low, and lithotomy. So Trendelenburg and lithotomy, this is known as the Lloyd-Davies position, and this is used for rectal and anal canal surgery, right? This is mainly used for rectal and anal canal surgery, like LAR. LAR is low anterior resection, which we've discussed in rectum and anal canal malignant disorders, low anterior resection. And APR, that is abdominoperineal resection. So these are the various OT positions also which you should know about. So before I end this module, I want you to understand the importance of this module is tremendous from the MCQ point of view, and when you actually start working as interns or when you start your practice. So definitely go through this module before your entrance exams. From the college point of view, not many questions are asked from this module, barring IV lines and sometimes OT positions. So very rarely you are asked about OT positions for final year students and IV lines. Otherwise, the main importance is practical and for the entrance exams. Now, as will be the trend in all the modules, we will cover few MCQs before the end of each module so that we can just reinforce what we've discussed in the module. So the first MCQ is that a patient in the surgical ward is suffering from prolonged paralytic ileus. After surgery, the bowel cannot contract, so there can be paralytic ileus. And the most common cause of paralytic ileus, I've covered in the bowel obstruction module, is hypokalemia, right? The consultant asks the intern to start potassium replacement for this patient. The intern asks the nurse to start it. When the intern returns, he sees the student nurse about to inject an IV bolus of potassium. Now, if you inject an IV bolus of potassium, that is sure shot death for the patient, right? There'll be a cardiac arrest. So the intern immediately stops the nurse. So this will classify as what kind of incident. So these clinical questions, you should identify the key words. And if you identify the key words, then you can find out the answer. So here, there was an incident, an unwanted incident which was about to happen, but it has been prevented. So this is going to classify as a near miss event. In which phase of the surgical safety checklist is site marking checked? This is the sign-in phase. This I've already told you. Equipment storage room is seen in which zone of the theatre? So I've already discussed the zones of the theatre, and I've told you that the clean zone is the one where equipment storage room is present. So the equipment storage room is present in the clean zone. A 32-year-old trauma patient after road traffic accident has a BP of 80 systolic. So hypotension and there is tachycardia. Right? Hypotension and tachycardia means there's at least class 3 shock and we need to infuse fluids quickly. So which IV line will you prefer? What did I tell you? We will use the widest possible IV line. And here gray is 16 gauge, green is 18 gauge. So which one will you prefer? We will prefer a gray cannula. We will prefer a gray cannula in these patients. During thyroid surgery, the inferior thyroid vein gets nicked by the assistant and the patient suddenly desaturates. During surgery, sudden desaturation and thyroid, I told you, head end is up. So, air embolism can occur, right? Air embolism can occur. We've already discussed this is our Lloyd-Davis position. And the best data to check the reliability of safety systems in a hospital, I told you this is the number of near miss events. Number of near miss events which is there. So these were some questions regarding this module. And that brings us to the end of the first module. In the next module, we will talk about how do we start the surgery, what is required. That means blades and energy sources. How do we control bleeding?